Hi, my name is Yuexuan. I'm a third-year PhD student from the University of Wisconsin at Madison. Today, I will present my work with the title of Effect of Pathway-Specific Polygenic Risk Score for Alzheimer's Disease and Rate of Change in Cognitive Function and AD-related Biomarkers among Asymptomatic Individuals. So, Alzheimer's disease is a major public health concern in the United States. In 2021, there are more than 6.1 million individuals suffering from AD, and this incurred more than $355 billion in the public cost. Genetics plays a considerable role in the disease pathology of AD, and the heritability estimate of all common forms of AD ranged between 58% to 79%, with the APOE gene as the known genetic risk with the strongest risk. All other non-genetic factors that contribute to the disease risk of AD include brain aging, exercise, lifestyle, and etc. Currently, there is no effective treatment that can stop or prevent AD, but the neuropathological change leading to AD, such as the biomarker variation or the preclinical cognition variation, occur decades before the clinical symptoms appear. So focusing on these outcomes can help people identify the disease at its earliest stage and take the targeted actions to delay the progression of the disease. So polygenic risk score have been widely used in the clinical settings and have been found to be served as a good predictor of the disease risk. An overall polygenic risk score, which is summed all the AD-related genetic variants and construct a score, can be efficiently to identify the overall disease burden of the AD, but its performance in the prediction of the surrogate outcome during the preclinical stage of the AD is still not clear. The pathway-specific PRS, on the other hand, is constructed based on the selected genetic variants based on specific biological pathways. The performance of the pathway-specific PRS have been validated in the prediction of the overall AD disease burden, but its performance in the prediction of the preclinical outcomes of AD is still in debate, and there are many mixed results. So the reason for why the recent publications on the AD-related pathway-specific PRS studies always give the mixed result, there are two reasons. The first is that the majority of these studies only rely on a single review paper or bioinformatic database to construct their pathway-specific PRS, but the gene function defined by different review papers and bioinformatic database is different. So this creates uncertainties in the construction accuracy of the pathway-specific PRS. And second, the role of aging is always ignored by these studies. We expect that during the preclinical stage of AD, the preclinical outcomes is changing gradually as people aging. But most of these studies, they only assume a constant age effect, and the sample they used have different age ranges. In our study, we widely browsed AD-related literature published in the past 5 years, and we do the variant pathway mapping. A specific genetic variant is included into a particular pathway only if more than 50% of the literature we reviewed gave the evidence of this variant pathway relationship. And we then construct our PRS based on the most recent, using the significant variants as identified by the most recent IGAP-GWAS meta-analysis with and without APOE, and we then compare their performance. Our meta-analysis was conducted using the data from the Wisconsin Registry for Alzheimer's Prevention, and we replicate all of our findings using the data from the Wisconsin Alzheimer's Disease Research Center. And we studied the preclinical overall and component cognition outcome plus 2 biological hallmarks of AD that include tau and beta amyloid. So I'm sorry, I don't know why the slide like this, but generally, most of our findings are very similar, but here I only select 2 to present here. So these 2 are very representative. So for the cognition outcome, preclinical Alzheimer's cognitive composite score, we found when APOE is included, the performance of the pathway-specific PRS is very similar to the overall PRS. But when APOE is excluded, the pathway-specific PRS has the potential to identify the early cognition deterioration than overall PRS. And all PRS can predict the cognition deterioration 5 to 10 years earlier when ApoE is included than when ApoE is excluded. And for the biomarker outcome, beta amyloid 42, we found very similar findings. So when ApoE is included, the performance of the pathway-specific PRS and overall PRS is very similar, and is primarily driven by ApoE. But when ApoE is excluded, the pathway-specific PRS has the potential to predict early abnormal variation of beta amyloid than overall PRS. And all PRS can predict the early abnormal variation of beta amyloid about 5 years earlier when ApoE is included in this PRS than when ApoE is excluded. Okay, that's all. So thanks for listening. I'm looking forward to your questions.